هي سؤال براكتس مختلف من مكان لمكان من طبيعة لطبيعة بس يعني نحاول نعطي شيء ستاندرد.
يعني وصلت 90 دقيقة.
90 طيب تمام. لا نحكي عن دي الشيء تمام. سكرين تمام. بالرغم يصير بدون هذا ناشونال سكرين مفروض صح؟ نعرف إنه وين people mention screening specifically screening by contrast. But the practice that we have بيقول just to X-ray all babies at the age of 4 months, 3 months, 5 months. هذا ما في هذا مش موجود بالنتيجة. هذا practice كله يجوز بالريجن موجود تمام. وليش هذا practice adopted؟ احنا ما عرفنا مع بعض نستخدمه لأن الباثولوجي is very common and we don't have a screening program. طبعا هذا البراكتس احنا still picking up tons of videos صح؟ which means if we want to skip هذا البراكتس معناته احنا راح كلهم هذول بنشخصهم على 4 أشهر و 5 أشهر راح يجونا على السنة ورا صح؟ having said that دي معلومة كثير مهمة إنه أنت بتصور على 4 أشهر they turn out to be dysplastic let's say AI 50 okay؟ احنا we initiate treatment صح؟ لا 75% of PDH patients have zero risk factors صح؟ أغلب الأطفال اللي عندهم PDH ما عندهم risk factors مرة selective screening programs جميلة بس قبل like physical exam speech family history ممكن إذا عنده cortical بس that's it. بس احنا حكينا إنه 75% of patients have zero risk factors. فكل dysplastic patients that we are treating recording اللي هم clinically silent ما في أي abnormality in physical examination and they don't have risk factors. مرة ولا عمرهم حياتهم يتصوروا بالأطفال. صح؟ برا بحكي وين؟ كندا عندهم public health system Scandinavian countries كندا ما حدا بصورهم بيجي البيبي ما في risk factors normal physical examination بحسب البيدياتريشن خلص عشان هيك عندهم شيء اسمه ايش؟ ليه كونسنت ديسبليزيا اوف ذا ادولسنت جو 12 13 سنه وعرفوا شوي فين من بين ترندلنبرغ بكون عندهم ايش؟ اول ديسبليزيا ريزيديوال نوت تريت هلا مع هيك لازم احنا نوسع شوي افاقنا انت the 4-month old baby with a 34 acetabular index annually should we treat them? We don't have it. No. I don't know the natural risk. عندك randomized prospective trial انه اذا جبت 100 34 او 4 شهور وعالجت جزء منهم ما عالجت جزء منهم كيف حيكونوا على السنه؟ We don't know. لانه public health and bracing in general was initially introduced for the unstable hips. Right? Not for the mild dysplasia that we are treating. So are we over treating? Potentially yes. بس يعني practice more. عشان تكونوا فاهمين. طيب. وذكرت البرزنتيشن علاش ما نستدي هذه؟
على الألتراساوند على التقديم تنزل من 1% تقريبا 12,000.
But nobody does ultrasound.
كل الأطفال أول ما ينولد.
Typically, ultrasounds are done 6-8 weeks. The only way directly after the birth or to rarely positive head. Yes.
محمد شرف.
Dislocated, you reduce. I need to confirm and I should share treatment or you. The bar positive head, you can wait. Like 6 weeks, 8%. But the only baby who عمل ultrasound mean by the way orthorannual bars يعني artist شوية تكون هي صحية عشان تقدر تكتب they are not very easy بس يعني هلا it's very common in pediatric patients or not also actions وليس instability مش تكرار إنه هذا اللي كتير كيس الأطفال بس مع هيك any baby with a click should be screened. طيب 4-month old, what would you do? 4 months old, is bilateral dislocation, correct? Bilateral dislocation, 4 months old, fabric?
Yes.
How long will you wait?
1
When you first reduce?
wait for simulated.
Okay.
First week, or you do first week solo on confirm about the congress. Not reduced 2 weeks, that's it.
Why would you change the rest of the race?
What's the
Because it's not reduced within يعني من وين هذا البراكتس؟ So this is let me tell you, like you go out and you attend the ICE, National Pediatric North America, to switch from flexible to rigid. Some people will do, okay. In bilateral cases, I will not. I don't think putting these hips in a rigid bracing. So don't be dramatic, and be flexible. Flexible bracing. Okay, if not, you may change to okay, not. Don't say it as a rule. We should change to rigid bracing because there's no consent. Okay, regardless. Okay. Yes, right. You could try up to 3 weeks. If the baby is too young, and still not reduced, break 2 to 3 weeks, then try again. If the baby 4 or 5 months of age, move on to something else. Okay, so we know that many creams are plastic and they are silent. We don't get to see that it's okay, right? Now, beware of the congenital ones. Born with hip dislocation, typically fixed dislocation, irreducible. Okay, I wouldn't try bracing. This is completely different. Congenital dislocation. So EDH should be reducible. It's fixed dislocation, congenital, it's completely different. Abnormal neuromuscular development. Okay, painful? No.
Yeah.
Not really. So why do we treat? Because we know the natural history. Okay, we know the natural history. Okay, and we know that there's causing issues like ABL. So ABL is not related to DDH, it's related to. Okay, we know this. We're going to go through the incidents. Multifactorial. Beware of the letter F. Risk factors, especially that. Family history and frank breach. Okay, all breech babies are at risk, especially the frank breach, 20%. Okay, and frank breach, regardless of the mode of delivery. Frank breach in the last 4 weeks, or breach in the last 4 weeks, even if born by cesarean section. Okay, so breach importance is the baby status in the last 4 weeks in the womb. Okay. Swelling, the only postnatal modifiable risk factor. All risk factors are prenatal except swelling. If you want to do anything, say swelling. Okay, leave the hips free, leave the legs free. Preventable, we talked about screening. Okay, selective screening criteria, abnormal exam, family history, or breach. Okay. The disease is different in the newborn, infant, toddlers, adolescents. In the newborn, it's in the form of flaxseed. As the child grows, you get some tissue contractions. Then, bone erosion, joint deformities, and then around arthritis. So the disease is different. Okay. You should know the obstacles, intra-articular and extra-articular ones. This guy actually got his death from a vigilant mom, correct? So the mom was changing the diaper and it was a click at once. So she came into him and okay. Barlow, look for the test. So when you do an autonomy or a Barlow, okay, you should fix one side and move the other. And it should typically happen within the first few degrees of infection. Every 7 minutes, okay? You shouldn't take all the way out. How do you own that? The first 2 degrees, you have done, maybe I see. And from the side, just the middle finger is deeper in the grip of the camera. Right? Okay. Asymmetry holds, not necessarily associated with yes, but if you see it, you should see the baby. Apparent shortening, Ariadne sign, limited A reduction.
Okay, so this is Lillian. She has a dislocated left hip. What you can see, if you just look at her. Okay, so this is Lillian. She has a dislocated left hip. Okay, so this.
Okay, ultrasound. We're going to go through the details. Classic is broad. Classification, static examination, hierarchy is called dynamic one. What do you think of this? Good. X-rays, you all know the parameters. You should know the lines and the lines, breakers, symptoms. These are important. Okay, know where the specific nucleus is. This is a dislocated hip. This is a dislocated hip. like suprascapular, okay, correct? Beware of the like suprasubluxed hips currently, okay, because of the position, like whenever you get the X-ray, at least do not keep the hips or the legs adducted, okay? Okay, because you know, for someone who's inexperienced, this is a subluxed, correct? For me, this is a normal. So why do we treat them? What do you think of the left side? It's plastic. Okay, so see the natural history. No treatment, no treatment. Still this plastic. Yeah. Okay. If he has a transient plus an algae cage, okay? See, like the difference between treating dysplasia early on or major PDO. Okay. How do you manage them? First 6 months, that's bracing. So gold standard is fabric. You should know how to apply the fabric. 90 to 100 degrees of flexion. Your abduction should be active. It's not forced abduction, it's active. Okay? You have to make sure that the baby does not go into full abduction, just 10 degrees shy of full abduction. Otherwise, the baby should freely abduct the hips. Okay, so you should not tighten the posterior straps.
5 minutes.
This is a rule.
5 minutes.
Complaints is an issue. This is our baby. Actually, did very well. This is the best outcome therapy. Okay. Rigid bracing has a rule. After that, you go in for a closed reduction or a medial open reduction. Criteria medial dipole, your rose thorn sign, put your spica in, beware of safe zone. You do not want to put the hip in extreme or the maximum available abduction. Okay. Get some sort of axial imaging to confirm, because sometimes you know it's reduced intraoperatively, but it's subluxed. So axial imaging is key. And these casts are not without complications. That's why early diagnosis is important. Okay. Worms coming out. Okay. A very nasty result of bilateral closed reduction. Okay. There's nothing you can do for this. After that, you go for open reduction. Okay. So this is my spica after an open. I would say favorable outcome for the baby. Nice incision. This one, waddling, okay, hyperlordosis, bilateral dislocation, cheek early. I'm not sure about the vascularity. Okay, avoid this, please. And avoid this. Okay. The complication are stop. When you do your capsulography, do that with details out. Take good of that. Regardless, whichever just yes. Yes.
This
Yeah, you know the principles: reshaping, redirectioning.
all your best.
Don't go through the details. Right? Myself hard to can't. Yes, redirection, reshaping.
يعني سؤال الدليل الرسبيكيشن تبع السنتر sign of the
Right. If you have an esticated head and you reduce the head, failure of ossification in the first year after reduction is called failure.
first
Failure within the first year.
Yes.
And typically dislocated head, the ossification is delayed in comparison with the other side.
Okay.
It's not alien, it's delayed ossification. Okay. Okay. So this is a 7-year-old limb pain, left hip pain. Okay, changes, crescent sign on the left side. Last follow-up came back after a few months. What do you think? Heading B, C? Okay. So Perthes described over 100 years ago. Pathophysiology is important. You get alien, you get absorption, you get collapse, fragmentation, healing, and remodeling. Okay. Demographics varies more in males, 6 to 7 years, no socioeconomic status, smoking in the home. And this is very important. We'll come to Joseph. Other classifications are fading of importance. You know the herring, less than 50, okay, or no reduction, less than 50 and more than 50. Sternberg, prognostic-wise, is very important. You need a Sternberg 1 or 2. 3s do bad. 3, 4, 5, they do bad, okay? See the natural history? This is one of the largest series. So they compared no treatment, range of motion, or bracing, no difference. No treatment, physiotherapy, or bracing, no difference. Femoral or pelvic osteotomy, no difference. However, they said that surgery for those above the age of 8, if they are B or BC, they do better. Now, the bad thing about herring classification is that it's based on late fragmentation. Okay? And Joseph from India have taught us that. So, summarize, practice is a stent-limited avascular necrosis. So, the rule, AVM, collapse, healing, remodeling. So, all head swell, remodeling. So, what we want to do is to keep the femoral head inside the acetabulum during the healing and remodeling phase. Now, the bad thing is that at some point, they start to get extrogens. So the head's coming out of the acetabulum. So that in the healing and remodel, it's not circular. Okay? So, Joseph found that if you intervene, not after the early fragmentation phase, the outcome is good. So if you can pick up these kids just at the early fragmentation phase, do something, contain the head, the outcome is good. If you're beyond that, then the outcome is not that good. And the head classification is actually based more on, so it's probably late. So if you're going to wait until you see the fragmentation and it's heading BC in an 8-year-old, you're probably a bit late. And here comes the importance recently of MRIs. They do something called subtraction MRIs, okay, the fusion MRIs. And based on how much of the epiphysis is perfused, you can predict that this is going to be a herring B. So you can intervene early. Okay? We're not go through these details. Dynamic assessment is important, okay, because your arthrogram gives you an idea of early impingement. Okay? How do we manage them? Containment, casting, bracing, varicizing osteotomies, pelvic osteotomies. You need to contain the head by any means. Okay. Sometimes, if not containable, you need to do some sort of distraction with a hinge or a static. Okay. Back to our kid. So, intraoperative arthrogram. I thought he was contained, so I varicized him, and I thought he did a very good job. 10 degrees, not more.
Why did you choose like femoral osteotomy?
That's good. He was 7, so I thought he would grow out of us. So it should be fine. Others would go for the pelvic side because they say, well, I wouldn't affect the biomechanics. He won't kill more. Okay. Okay. However, over time, unfortunately, he collapsed and he did really bad. So still, it's unpredictable. Okay. Few things about skipping. So slip capital, okay. What did you do for this one? Incito, reduce or incito. Okay, so we'll see. Epidemiology, you know that bilateral in 50%. Beware of the mechanics and the endocrine factors. Through the hypertrophic layer, this is very important. So when you get slipped, the femur neck goes anterior and into external rotation, correct? And the epiphysis stays inside. So the anterior vessels are disrupted. So you are typically left with the posterior ones. And these are very important to maintain. Okay? In terms of AVN risk. Signs, you know, the pre-slip, the epiphyseal branch sign, could be acute, chronic with remodeling, acute and chronic. These are fading, like these are not important in this time. The loader is more important, stable or unstable, correct? And when he put his classification way back in the 90s, like this is subjective, right? It's purely subjective, the patient's able to bear weight or not. However, the importance for stability is that if the epiphysis is stable over the neck, so the risk of AVN is low, or is the epiphysis moving freely over the neck? So there's a risk of disruption in the posterior vessel. Okay. Clinical, so aim, prevent slippage. So when you think of treatment, this is Shankar from Vanderbilt, very nice classification. It's immobile, the risk of AVN is low. It's mobile, the epiphysis over the neck, the risk of AVN is high.
How will you know?
Intraoperatively, based on CR image. CF. They are moving in one piece or not, okay? So pinning one screw, even for the unstable ones, I would say, try to get perpendicular, more anterior, proximal entry, the more severe the slip is, okay? Osteotomies have to be experienced. Prophylactic pinning in my book, young, less than 10, open triradiate, endocrinopathies, and if the patient is living in the rural areas, the follow-up is difficult. I will pin the other side, because pinning the other side is not always risk-free. Okay? If you have a child living in a man, without risk factors, do not pin the other side. Chondrolysis, so you get stiffness, reduced joint space, avascular necrosis, delay in diagnosis, most important single risk factor for poor outcome. Okay, the later the diagnosis, the worse the outcome, and the severity is important. How do you pin them? One screw, at least 3 to 4 threads across the physis. I use 2 threads or 40 threaded screws because the metastasis is weak and it's easier to take out. Okay, avoid the anterolateral segment because if you get AVN and collapse, your screw is not inside the joint. Okay, it won't get prominent. And the entry point distal to the intertrochanteric line. Persistent pain 3 to 4 weeks after fixation. What's your prevention? Unstable fixation, pin penetration, infection, or chondrolysis. Okay. Next. You don't have to enjoy this is a gliding screw. They use it for younger kids. Triradiate is open because you fuse the physis early, you will end up with labeling discrepancy and short legs. This is a gliding screw that allows drop while maintaining the contact. Again, back to the patient. Ended up with AVN. Thank you.